Hello, everyone. Welcome. It's my pleasure to bring you here today for our virtual NBC Impact Series event for the month of May. My name is Casey Volpe, and I am with Susan G. Komen's Community Education and Outreach team. The programming for this series is envisioned as a year-long conversation with attendees where we cover new information and new speakers every month. And today we have our first Ask Your NBC Questions event of the year, and the focus will be on diagnostics and treatment. We have two fabulous panelists for you. That is Dr. David Mankoff and Dr. Susan Domchek. So please note real quick, our speakers are not going to be able to provide individual medical advice. So just do your best to keep your questions as general as possible, and we will get through as many as possible, as much as time allows. Before we begin, Komen has to thank our sponsors for supporting the NBC Impact Series for 2023. So thank you to AstraZeneca for being our technology sponsor for this year's event. The virtual setting means NBC patients, no matter where they are, can be part of this community. We would also like a special thank you to our premier sponsor, GE Healthcare, for their support of today's event. And last but not least, signature sponsors, Walgreens and Merck. One more housekeeping note before we get things kicked off. While our speakers are talking, please post your questions in the Q&A feature. As I mentioned, there just never seems to be enough time to get to everyone, but we will do our very best. So now we're very excited. You all are joining us for today's discussion. And to start, I'd like to introduce you to our moderator, Jamil Rivers. And I'm just going to let the slides come up. Perfect. Thank you. So Jamil, at 39 years old, was diagnosed with metastatic breast cancer de novo. The determination to fight and survive for her family launched her into a vigorous research to understand and contend with breast cancer. The extensive research she undertook along her own journey became the foundation of a lifelong commitment to explore and enact optimal and comprehensive breast cancer care. She went on to participate in numerous community health events, which facilitated the design and funding of 2 metastatic clinical trials. This afforded her the opportunity to meet with leadership within the Pennsylvania governor's office and congressional leaders in DC. She became an advocate using her knowledge base and experiences to help advance legislative policy, medical research, and customized support to better meet the needs of individuals who have breast cancer, particularly metastatic, Black patients, and other disparate groups. In addition to serving on numerous boards and supporting many breast cancer organizations, she is the founder of the Chrysalis Initiative, which was born from her own experiences offering guidance to women on how to thrive with breast cancer. She, her husband, and their 3 beautiful children live in Drexel Hill, Pennsylvania. So Jamil, the floor is yours.
Thank you so much, Casey. I'm so excited and honored to be here today. Me and my family are now New Jerseyans, so I just wanted to add that. And I also have the honor of being board president of Mediviva Research and Support and serve on the board of Living Beyond Breast Cancer. But I'm really excited about this series. I love this series because we get to learn so much about NBC and all the latest and greatest research and technology for us to have a solid quality of life when it comes to living with metastatic breast cancer. And so I am looking forward to both presentations today. So I want to introduce both of our panelists today. First is Dr. Susan Domchek. She is the Bassler Professor in Oncology at the Perelman School of Medicine of the University of Pennsylvania. She serves as Executive Director of the Bassler Center for BRCA at the Abramson Cancer Center and Director of the Marion and Robert McDonald Cancer Risk Evaluation Program. Her work focuses on the genetic evaluation and medical management of individuals with inherited risk factors for cancer. Dr. Domchek is particularly interested in developing new cancer therapies, such as PARP inhibitors for breast cancer, due to genetic risk factors. An elected member of the National Academy of Medicine, the American Society of Clinical Investigation, and the Association of American Physicians. Dr. Domchek is also a fellow of the American Society of Clinical Oncology, a significant contributor to the oncology literature. She has authored and co-authored more than 400 articles appearing in scholarly journals, including the New England Journal of Medicine, the Journal of the American Medical Association, and the Journal of Clinical Oncology. Dr. Domchek also serves on a number of editorial review boards, as well as on the Scientific Advisory Board for the Breast Cancer Research Foundation. Dr. David Mankoff is the Matthew J. Wilson Professor and Vice Chair for Research in the Radiology Department of the Perelman School of Medicine at the University of Pennsylvania. He also serves as the Associate Director of Education and Training for Penn's Abramson Cancer Center. He practices nuclear medicine at the University of Pennsylvania with a special interest in oncologic applications of molecular imaging and radiopharmaceutical therapy. Dr. Mankoff's research focuses on molecular imaging of cancer, primarily for breast cancer, and emphasizes molecular imaging biomarkers for precision oncology, therapeutic monitoring, and identifying biologic factors, mediating therapeutic response and resistance. He translates of new molecular and quantitative imaging methods into clinical trials and clinical practice. Dr. Mankoff is a Komen Scholar for the Susan G. Komen Foundation, Scientific Program Committee Co-Chair for ECOG Akron, and Co-Chair of the Radiologic Society of North America RSNA Research Vice Chair Group. Dr. Mankoff is a past member and president of the American Board of Nuclear Medicine and is on the editorial boards of Nuclear Medicine and Biology, Radiology Imaging Cancer, and Clinical Cancer Research, and serves as an associate editor for the Journal of Nuclear Medicine and deputy editor for Breast Cancer Research. So I'd like to welcome Dr. Damchak in order to get started with the first presentation.
Great, thank you so much, Jamil. And one update since I put in my bio is that I am again a Komen Scholar. I was a Komen Scholar and then wasn't one, and now I am one again. So I'm thrilled to be here to talk about metastatic breast cancer. So if my slides can come up, I will get us started. I'm going to be starting with just some general discussion about diagnostics and how we approach this in metastatic breast cancer. Next slide. So when we talk about metastatic breast cancer, it's important to sort of take this step back and make sure everyone knows that there are different types of breast cancer and these equate to different treatments. I think many people who haven't unfortunately learned a lot about this by personal experience think that there's really just one type of breast cancer. But the three main forms of breast cancer are those that are estrogen receptor positive and HER2/neu or ERBB2 negative. Then we have HER2/neu positive breast cancer, which in the past we defined as IHC3+ or FISH positive. I'm going to talk about how we determine these things in a minute. And then this third group, which is triple negative breast cancer, which is negative for estrogen receptors, progesterone receptors, and HER2/neu. And we really do view these three main buckets of breast cancer as very different, and we treat them very differently. Next slide. So when you think about metastatic breast cancer 8 years ago, we actually had fairly limited non-chemotherapy options. Yes, we've always had chemotherapy, but in terms of non-chemotherapy options, there were options for HER2/neu positive breast cancers. There was a drug called everolimus, which we used with hormonal therapy, and then there was hormonal therapy. And since that time, next slide, you'll be happy to see how many drugs we have added to our list. And so this is a real testament to not only science, but also individuals who have gone on to clinical trials. So this is a shout out to all of you out there who have joined clinical trials to help advance the field and to discover new therapies. So again, this is just a list. I'm not going to go through each one in detail, but it just gives you a sense that we have a lot more tools in our toolbox that we did just 8 years ago. Next slide. So how can we figure out who needs what? So there's a couple of things that we do. One is that we do genetic testing, and genetic testing can be either the germline, which is testing the DNA that you're born with, and testing the tumor. We call that somatic testing. So the things that you're born with, genes that you're born with, that's germline. Changes in the tumor, that's called somatic. And when you look at the genes that a person is born with, again, this can be tested by a blood or a saliva test. This does have implications for family members because it can, if an individual has a gene mutation, it's a 50-50 chance that it can be passed down. And it's usually also detected in the tumor. Genes in the tumor, if someone has negative genetic testing in the blood, you can still have genetic changes in the tumor that lead to a change in therapy. And again, we call this somatic testing or tumor testing. changes that only occur in the tumor aren't passed down from generation to generation. And again, this is testing tumors or increasingly by testing blood. And so this is, sometimes we see something in tumor that's also in the germline, and sometimes we see things that are just in the tumor and the tumor only. And again, this somatic sequencing can either be done by a biopsy of the tumor or by doing what's called the liquid biopsy, taking blood and sequencing DNA from the tumor that's in the blood. Next slide. In addition, immunohistochemistry is a very important part of how we look at breast cancer. And there's a very big word, but basically we use antibodies to stain for specific proteins in tumors. And currently we don't have any really good assays to do this in the blood. There are some things that are out there, but realistically, the best way to do this is to do a tumor biopsy. And usually we pretty much always try to get an initial tumor biopsy when an individual presents with metastatic breast cancer. And what we're looking for is estrogen receptors and progesterone receptors to figure out whether the tumor will respond to hormone therapies. And we also are looking at HER2/neu. And what has changed over the last, mostly over the last year, is that in addition to tumors that are HER2/neu positive by traditional methods, meaning 3+ or FISH positive, which is what's shown below, on the left is the immunohistochemistry staining, the protein staining, and on the right is something we call FISH, fluorescent in situ hybridization. And this is an example of a very strongly HER2 positive cancer. But now we know that tumors that are HER2 low, which is 1 or 2+, also can respond to a specific HER2 directed therapy called trastuzumab deruxtecan, also known as Enhertu. So this is why we want to do the immunohistochemistry of the tumor. For triple negative breast cancers, we also test for PD-L1 to give us a sense of whether immune therapy will be indicated. And we also test for things called mismatch repair proteins, which are not commonly altered. Whoops, I don't know what happened there. Can you go back to the other slide? They're not commonly altered in breast cancer, but when they are, it has implications for therapy. Next slide. So when we talk about how treatment is determined, if we go on the left-hand side for estrogen receptor positive HER2 negative cancers, we look at specific mutations in the tumor called PI3 kinase mutations. That gives us a sense of whether to use a drug called alpelisib. We look for ESR1 mutations because recent approval of a drug called elacestrant is now available. We look for BRCA1, BRCA2, and PALB2 mutations because that gives us insight on whether to use a PARP inhibitor. And we do also look for HER2 low tumors to use trastuzumab deruxtecan. For triple negative breast cancers, again, we're looking at PD-L1, BRCA1, 2, and PALB2, and HER2 low. And traditionally for HER2 positive, we're still using immunohistochemistry. For all tumors, we're also looking at NTRK fusions. This is a very specific genetic alteration, and looking at deficiency in mismatch repair. That's the mismatch repair proteins. And these latter two, NTRK fusions and mismatch repair, there are what we call tumor agnostic approvals by the FDA for these drugs. And that means the FDA has said it doesn't matter what cancer type you have, if there's an NTRK fusion present, that there is a drug that might work. Similarly, as if there's evidence of mismatch repair, individuals are candidates for immune therapy. So when I think about a patient with metastatic breast cancer, I want to know all of this information when I'm making a decision about treatment. Next slide. So how do we measure, how do we monitor whether cancer is responding to therapy or not? Well, there are tumor markers, and these are not really proteins, but molecules that are in the blood. CA2725, I apologize, that's a typo. CA15-3, CEA, and CA125 are the common ones that we measure in the blood. And in metastatic breast cancer, we can follow these markers. They often, but not always, give a sense of how the tumor is responding. So if they start really high and they go down, that makes us feel great. But markers can fluctuate. So I really encourage patients not to make too much of small changes because they really can be not important. And we also try not to check them too much for that reason too, because of these small alterations. And sometimes they might go up a little, but our scans, which we're going to hear more about, look good. So we like to not over-interpret these markers. So how do I, as a physician, decide whether the therapy I'm giving you is helping? Well, the number one thing is how somebody feels. And we recognize that cancer can make someone feel ill, but the treatment can too. And in the end of the day, what we're trying to do in treatment of metastatic breast cancer is improve both quantity, but also quality of life. So that's an incredibly important thing. We use scans, and you're going to hear from my colleague, Dr. Mankoff, in a minute. And to a lesser extent, we use tumor markers as sort of ancillary information. So that's sort of my big picture. And I think that this is a really good segue into learning more about the scans and the CT scans and PET scans and other things that we use. And so I'm going to hand it over to my colleague, Dr. Mankoff. Thank you very much.
Sorry, now I'm unmuted. Thanks very much, Susan. And if we can have the first slide, that would be great. And I want to start by saying the same thanks to folks on the call that Susan did. Is I've done a lot of my research on novel approaches to imaging, and those are only here and in place in some cases in the clinic because of folks that have participated in this topic. So I'm going to talk to you a little bit about how an imager can help you by answering your metastatic breast cancer questions. And as mentioned, I'm also happy to be returning as a Komen Scholar like Susan I was for a while, and I'm back. So next slide. Thank you. I want to ask this about some what ifs about diagnosis and detection. What if we could identify patients with metastatic breast cancer at a stage when they were more amenable to treatment? What if we can determine if the treatment is working and working early after treatment? And what if we could actually use imaging to help guide treatment? Next slide, please. So what I like to do is spend a little bit of time going over what the different modalities are and to explain a little bit about how they work. And if you could hit a click one more time, that will give some information as this comes up. For screening and detection, I think many folks are used to mammography, and I'm sure many of you have or are continuing to participate in mammography. And its closely related cousin, digital breast tomosynthesis, which is a 3D version of mammography. Both of these use X-rays and look at density of the breast as a way to diagnose abnormalities. You're also familiar, I suspect, with ultrasound, which can be used in breast and other areas. And this uses sound waves, again, a non-radiation approach to be able to image structures of tumors. And then again, many are going to be familiar with breast MRI, which uses electromagnetics and magnetism and radio waves to be able to look at tissue characteristics, which give you both functional and structural pictures. When it comes to staging, we use a slightly different set of studies. And again, when I talk about staging, we're talking about looking for spread to regional nodes and looking to spread for distant sites in the body. And in the latter, that's typically how we define metastatic breast cancer. Computed tomography also uses X-rays, but it uses it in an image reconstruction approach that fundamentally uses mathematics to recover an image of a three-dimensional picture of your body. A body MRI does the same thing, applied in this case to the whole body, not necessarily just to the breast. And I'm going to talk to you a fair amount about what I do for a specialty, and that is to use radioisotopes. You've heard about this in names like nuclear medicine. Some of the modalities we use are positron emission tomography or PET, and a bone scan is also an example of these tests. And these are also images that can be created from the emissions that come from these radioisotopes, and they can also be done three-dimensionally. Next slide, please. So what about if we could find breast cancer earlier and with more accuracy? Next slide, please. So I'm showing you on the left an image reconstruction of a CT. You are looking basically up from the patient's feet. You see the two breasts there. The bones appear as white. The lungs appear as dark because they're not very dense. The bones are quite dense. And you can see a fair amount of structure in this area. And we can often identify abnormalities in the lungs, the regional nodes, the liver, and other places on the basis of seeing things on these scans that we're not expecting. On the right, you see radioisotope imaging that is done with a bone scan. This is actually a radioactive material that's a phosphate that's part of the incorporation and development of new bones. And because many cancers will alter the formations of bones and cause excess new bone formation, we can see them on a bone scan. Next slide, please. One of the newest technologies is positron emission tomography. I sometimes call this physics and chemistry meet biology. This is a rather involved process that requires the development of short-lived radioisotopes such as F-18, which is a positron emitter. Those on a very close by site. This happens under our nursing school close by at Penn, to incorporate this into a chemical to make a radiopharmaceutical. From that, we will make the radiopharmaceutical injected into the patient. The most commonly used radiopharmaceutical is fluorodeoxyglucose, or FDG. This is what people come to think of as a PET scan. And this is a tracer of sugar metabolism that is elevated in tumors. Now, unfortunately, you can't starve the tumor by stopping sugar because your brain also uses sugar and you need that. But outside of the brain, most tissues will not use sugar at the rate that tumors do. And what you can see in the picture on the bottom is that thing that looks like it's glowing in the right breast at that point, which is an area that has increased glucose utilization and does a very good job of pointing out where tumor sites are. And this is taken in a specialized scanner that can do both PET and CT at the same time. You're seeing that fused image on the bottom. Next slide. So what can happen here is the ability to be able to use these two modalities to detect tumors that would otherwise be difficult, tumor sites that would be otherwise difficult to detect. So what you're seeing, and in my slides, something that is black has more radioactivity. And so what you're seeing in the top is the radioactivity image that shows there's a fair amount of increased glucose consumption going on in the breast. What would be a little bit harder to discern, unless you were very good at reading CTs, is the fact that this particular has spread to nodes that live in the anterior part of the chest, called the internal mammary nodes and the mediastinal nodes. And when you look at that on the PET scan in these three-dimensional images, that becomes quite obvious and becomes a very sensitive technique for detecting these additional abnormalities. So with many of these approaches combined, we can identify sites of spread at an early stage for appropriately staged patients, and can actually make decisions about how to guide surgery, how to use radiotherapy, and how to treat the patient based upon these scans. Next slide, please. Okay. Well, what about if we could determine if treatment is working early after starting treatment? Next slide, please. One of the areas where this is very important is in trying to look at the response of bone metastases, the spread to the bones for tumors. And this is a very common site of spread in breast cancer, especially for ER-positive, estrogen receptor-positive breast cancer. And so in nuclear medicine, we are faced many times with the scan that we show you today. You'll have to take my word for it that pre-treatment, this shows numerous subtle abnormalities throughout the spine and the ribs that is indicative of a metastatic disease. Patient went on therapy for 3 months afterwards. And one of the challenges with bone scans is it's actually very difficult to identify changes in the bone scans because they take time to evolve. A bone scan is a very sensitive way to look for a tumor, but it's actually a rather difficult way to look for change in the tumor. So I asked the question of these two scans at many meetings to nuclear medicine specialists who thinks this is a response, who think this is not a response, and people have a lot of trouble with that, who thinks we need a better way to look at that, and everybody raises his or her hand. Next slide. So this is an area where positron emission tomography can be very helpful. And in particular, in the bones, what you can see in this patient that has disease in most of the bones of her spine, you can see very elevated glucose metabolism, as you see in the diagram on your left and the fused image on your right. And we can see relatively early changes over the course of months, and in this case, in recent publications coming from our center at Penn, as early as four weeks, as a way into early insights into response. And so not only we're developing tools that can stage breast cancer, but there can be some additional ways to try to identify at a relatively early stage of treatment, more commonly in the order of 6 weeks to a couple of months, whether or not that treatment is working or whether things are going in the wrong direction. Next slide. So the last thing I want to go through is what about if this treatment not only can tell you where the disease is, but tell you how to guide it. And next slide, please. And this is getting back to the estrogen receptor that Susan talked to you about before, which is one of the most important targets in breast cancer, knowing that approximately 70% of newly diagnosed breast cancers will express the estrogen receptor. And we can use hormonal therapy and a variety of other therapies to target metastatic breast cancer with these features. Next slide, please. Now, in the last couple of years, we've had the approval of an agent that I've worked on for a while that is called fluoroestradiol. This is in essence a radioactive version of an estrogen, and it goes specifically to those sites that have increased uptake. We can see a pair of glucose scans and estrogen scans on the left in a patient with estrogen receptor positive disease and multiple sites identified. The patient on the right had recurrent disease from an estrogen receptor positive, but that disease had lost its estrogen receptor on the way to metastasis. And we see plenty of uptake in the glucose area, but not in FES, and we just see the normal pattern of excretion. Next slide, please. This is also emerging as a possible way to be able to do a better job of staging and identifying those tumors that are pretty tough to find this way, for example, lobular breast cancer. And while it has yet to hit the clinic, there's thought that there's going to be increasing utility from some of these specialized PET scans like fluoroestradiol to try to find some of these unique tumors that pose significant problems. Next slide, please. So the last question is, why doesn't everybody get a PET scan? And I think this is important to understand, is these tests, when very powerful in something like a PET or a CT, can be very accurate, and they can detect disease 90% of the time that it's there. We call that sensitivity. They can detect the absence of disease accurately 90% of the time, which we call specificity. But in patients with early stage breast cancer, less than 3% of them will have distant metastases. So if we were to go through this exercise for 1,000 patients, we are looking for no more than 30 patients that have this disease. And because of our limited specificity, a PET scan would detect 97 patients falsely positive. And so if we take an unsuspected patient, a low incidence patient population, such as early stage breast cancer, some people say, I've had my breast cancer treated and taken out, why don't I get a PET scan all the time? Is because the risk is so low, we're going to uncover three false positives for every time we find the disease. This has a number of effects of harm, which include biopsy, anxiety. And so one of the things I think people often want to know is, why don't I just get one of these scans all the time? And this is some of the math that demonstrates that. So in my last slide, one of the ways that dovetails with the types of things that Susan mentioned in her talk is the idea of getting increasingly sophisticated blood markers. Blood markers are relatively simple to get and test and have a reasonable amount of specificity. We can use these blood markers as a way to identify the possibility of recurrent disease and help trigger an appropriate use of PET scans. This is not yet routine practice, but something that could evolve over time and also be a way in complementary fashions to identify whether or not the tumor is responding, where we would expect the blood markers to go down and the scans to get better. Last slide. So what if we could identify patients at an earlier stage? We can do that. What if we can determine if the treatment is working earlier? We're getting better at that. What if we can help guide treatment? We're continuing to work on that. We have the one test that I showed you approved right now, and Komen funding has helped. And what if we could integrate what we can do in tissue and markers to do a better job of identifying metastatic breast cancer early and helping to decide whether or not it's responding to therapy? So with that, I will thank you, stop, and I think it's time for questions and answers.
Yes, it is. So first question, if you are on current treatment and doing well, can you still be a part of clinical trials, or is it risky to mess with your current treatment, which may change how well you are doing?
I can start with that one. Most clinical trials are meant for determining the response to therapy. And because they're determining response to therapy, the tumors in general are sort of growing as you go into that clinical trial. So you're changing your therapy and looking to see whether there's a response. Having said that, there are situations when that's not true. There are certain types of clinical trials where we do what's called maintenance. And we actually enroll patients who are doing well on a particular therapy. And then we basically change their therapy to something that might, for instance, be better tolerated. So it's not that it's not a hard no, but most clinical trials of new drugs are for individuals where their tumors have gotten worse. The other thing I will acknowledge up front, we talk about clinical trials, and sometimes it can be frustrating because we talk about clinical trials, and then people try to get on clinical trials and then they can't get on the trials. And I understand that that's frustrating because a lot of our clinical trials are sort of front loaded in what we call the first and second line, like right when people are diagnosed or after they've received a line of therapy or two. And sometimes your physician might think that the standard of care that we have is so good that we might not think that the exact trial is the right fit. But keep asking is all I will say, because we appreciate you asking, and we appreciate the opportunity to each time look and make sure whether or not there's a good trial for you.
And I think the only thing I would add to that is in many cases, you can be on a conventional treatment just getting started. There will be often what we call biomarker-driven studies, sometimes imaging, that are testing new approaches to guide treatment, make better treatment decisions. That's how you saw a lot of the output of what I saw today. So there are ways of participating in other clinical trials, even if you're not going to change your treatment.
Thank you. Could you talk about capivasertib and how it compares to Piqray in terms of side effects and effectiveness? From what I understand, it is being considered for FDA approval. Any projections on when it might be approved?
Yes, I am not in the know on the timing. It is so just to sort of take this step back, these are drugs that are targeting tumors that have PI3 kinase mutations. Alpelisib, which is Piqray, has been a drug that we have used in this setting. Its major side effect is an elevation in blood sugar, which can actually be significant and often requires that we need to put people on medications to basically effectively treat diabetes. We do not have any head-to-head comparisons of these drugs. There was a very nice study that was presented combining the drug that I can't pronounce. So by the way, we have trouble pronouncing these drugs too. We practice with fulvestrant. And so this is being considered for FDA approval. Right now, it's not commercially available for this indication. And I think that I think we're not sure. I mean, we obviously want a better sense of head-to-head which agent might be better tolerated. So I don't have a great answer for you, but it's always nice to have options. We, in many cases, like CDK4/6 inhibitors, we've got palbociclib, abemaciclib, and ribociclib. They have different side effect profiles. We choose one over another depending on the situation. PARP inhibitors the same. So we always like when we have more than one option available.
Thank you. For MBC patients, we know treatments are limited and many have terrible side effects. How can patients approach the catch-22 of treatment versus side effects for a better quality of life as possible? For example, an infusion is given twice a month, but the rest of the month, the patient is debilitated by side effects.
Yeah, this is such a great and important question. And, you will have noticed that I commented that our goals in treatment of metastatic breast cancer are quantity and quality of life, right? We want both. It is not if we double the quantity of life and have the quality, we didn't do a very good job. So, our best drugs, the ones I'm most excited about, are when we, sorry, all of a sudden my battery's low. Our best drugs are when we do both, when we improve both quality and quantity of life. And so, I'll give you an example. Olaparib and talazoparib's approval for BRCA-related metastatic breast cancer, we showed an improvement in how long it took for cancers to grow again, but also a significant improvement in quality of life. So the FDA considers quality of life in its approval of drugs. So if there's not an overall survival benefit, but there's an improvement in quality of life, the FDA will look very favorably on that, as opposed to sort of a very modest approval in how it slows down the tumor growth, but a worsening of quality of life. That's going to not do very well. So as an individual, I think it's really important to have conversations with your physicians about this, because, you know, we take breaks. We have to say to ourselves each time, is the reason that you don't feel well, is it the treatment or is it the cancer? And sometimes that's not always easy to tell, but it's our job to work with you to figure that out.
Well, you mentioned that the PD-L1 biomarker is targetable by immunotherapy in triple negative breast cancer. Anything on the horizon relating to PD-L1 for ER positive breast cancer?
Yeah, it's a great point. I mean, I think that you know, immune therapy has been you know, much further along with triple negative breast cancer, both in the metastatic setting, but also in the what we call the neoadjuvant setting, which is, you know, when we give treatment before surgery. Triple negative breast cancer now routinely gets a regimen called KEYNOTE-522, which includes immunotherapy. The reason that we don't routinely use immunotherapy in ER positive breast cancers is that it's sort of fundamentally, if you will, a cold, what we call an immunologically cold tumor. It just doesn't respond very well to immune therapy. So a lot of the goals in metastatic breast cancer for ER positive disease is, how can you turn that cold tumor hot? How can you make it more immunogenic? And I think that there are a lot of potential strategies that are out there for this, none of which are quite, you know, there yet. But just as a reminder, a drug like sacituzumab, which is something called an antibody drug conjugate, is an antibody linked to basically a toxin. And sacituzumab was initially approved for triple negative breast cancer, but then studies showed that it also worked for ER positive breast cancer. So we haven't, we promise we haven't abandoned the idea of immune therapy in ER positive breast cancer, but we still have to work on how to make that better, because immune therapy, by the way, isn't risk-free either. We do, that has its own set of unique side effects. So we need to know that it works for us to subject people to the side effects.
Absolutely. Also, Dr. Minkoff, feel free to cut me off or chime in.
I think there's a PET CT question in there. Jump to that one.
Well, I'll start with the imaging and diagnostic technology and then jump down to it. So this one is, what imaging or diagnostic technology do you think was a game changer for oncologists treating people with MBC and why? And I'd like to say with this a little bit of a future direction is that I think where we're going on the diagnostic imaging is what you saw of as an example of estrogen receptors. One of the problems with metastatic breast cancer is the disease can be quite heterogeneous, and it's really impossible to biopsy every site. It's not particularly reliable, let alone uncomfortable and impractical. And so there's a game changer if you can use imaging as a complement to biopsy, especially in metastatic breast cancer, where you can image the entire body burden. So the first approved agent that does that so far is this agent designed for the estrogen receptor, but there's a number of things that are in various stages of development that are, again, looking at other targets. For example, we are working on immunotherapy targets. We have things looking at HER2. We have targets that are looking at PARP inhibitors and other targets that Susan mentioned earlier. So I think the idea that we're going to have imaging that is customized, especially in metastatic breast cancer, to help guide therapy is an evolving game changer. The other game changer I'll go along with this was the last slide that I showed you, and that is circulating markers are getting more sophisticated, and in particular, circulating DNA can identify the presence of tumor quite sensitively and may even hold promise for identifying what features are mutated and what are different about that cancer. The blood samples everything in the body, and so it's a way of identifying tumors and tumor changes very sensitively. And if that tumor marker informs what type of imaging you might be using to look for, that's going to be a game changer as well, because we're going to be able to to really make our imaging not only more sensitive, but much more useful and much more specific. I might jump down to the related question down about a PET scan showing no active metastases, but fluctuating blood markers. So again, as I said before, blood markers will sample the entire body. The PET scan, for example, will show you where that tumor might be. There's a couple of reasons those can be fluctuating. You may see tumor markers before you have something that's big enough to show up on a scan. And so there may be subclinical or submacroscopic fluctuations in that tumor that may not show up on any type of scan, but where the blood markers may be sensitive enough to see those fluctuations. We see that, for example, in some of the markers used for prostate cancer, for example, or other types of cancer. The other possibility is the timing can be off. So sometimes we will see a fair amount of disease on a PET scan. People have high tumor markers. The next time we do a PET scan, depending upon where we do it, we'll see what looks like a response. And sometimes, depending upon where we caught the tumor markers, they may actually transiently go up as you're killing tumors and releasing these markers before they go down. So these things can be out of sync, but importantly, they can be on a different scale. And many times you're likely to see a change in a blood marker when you don't see changes in imaging. You really need to follow that over time to understand which one's giving you the most accurate answer.
Thank you. How is quality of life defined by the FDA?
Yeah, these are great questions. So there are specific tools that are called health-related quality of life questionnaires that have been sort of validated. There's a number of different ones, ECOG, there's something called FACT-B, not to get into too much of the details, but they're really specific questionnaires that ask about, your activities of daily living, your fatigue, nausea, vomiting, diarrhea, and just an overall sense of your quality of life. And so, the studies are increasingly incorporating these health-related quality of life measures into their protocols. So it's predefined. So you don't get to just decide at the end that the quality of life was good, right? You actually have to say going in with the protocol being designed that you're going to look at these specific measures and what you define as better or worse quality of life. But this is where patient-reported outcomes come in. So these health-related quality of life questionnaires, they are from you. You are telling the investigators how you feel. This isn't, the doctor deciding how you feel, because we know from, many studies in the past, like, we're not that great at it. We're really good with things like your blood count is low, and we can mark that as a very specific measure. But it's also true that sometimes patients don't always tell us exactly how they're feeling. You know what I mean? They rev up to get into the appointment and you know what I mean? And it's important to tell your doctor how you're feeling, but these patient-reported outcomes where you're just answering the questions directly have been shown to be the most effective way to really tell how people feel. And so, that was a long answer to the short question, but it is a specific measure, not just sort of a general sense.
Got it. What imaging or diagnostic technology do you think was a game changer for oncologists treating people with MBC, and why?
I think I did that one already, Jamil. There's
Oh,
one
you
on
did?
the-
Okay.
David skipped ahead. So
Skipped ahead. Yeah, I jumped, sorry, yeah. So, but there's a number 9 question now that I'm seeing, and that what are the limits of current imaging technology? And basically there are 2 limitations to diagnostic non-invasive imaging that are somewhat countercurrent sometimes. One is what we call spatial resolution. How small of something can we pick up? Can we pick up something that is a single cell? Probably going to be pretty tough. Can we get something that is maybe a few millimeters? Yes, we're starting to get there with much of our technology, and we're already there for some components. The other backdrop of that is the other thing that it influences our ability to find tumors is contrast. In particular, how different does the tumor look from the normal tissue? So for CT, for example, the tumor looks a little bit of different shape and density, but without contrast or something else to find it, it can be pretty tricky. For a PET scan, which has somewhat more limited spatial resolution, you can see the tumor standing out from the background quite well if the tumor or normal tissue features are better. So there's a couple of areas of technology for doing this. The machines are quietly getting better and can get better and better image quality and spatial resolution, often with shorter periods of time, lower dose in the case of lower radiation dose in the case of PET and CT. The other process in this is there are both instrumentation technologies and the diagnostic imaging probe technologies that are doing a better and better job of creating contrast between the tumor and the background. So even if something's relatively small, you might still have a chance of seeing that. And as Susan mentioned, there's many different flavors of breast cancer. There's some things that might work for an ER-positive breast cancer that doesn't work for a triple negative. And we're seeing more and more different agents to be able to look at this. One of the areas of excitement that's coming mostly from Europe, still quite experimental, is finding tumors, not so much because of what the tumors do, but what some of the tissues, for example, fibroblasts, structural tumors, do in the background. And there's a great deal of excitement on using probes that are looking at that that are at a very early stage of development. So it's a very complex question, but it comes down to how small can you detect, and can you distinguish the tumor from something that's normal tissue?
Got it. Any response to Trodelvy being given for MBC? Is it best when paired with another medication, for example, Kisqali with fulvestrant?
Yes, and by the way, I tend to always try to use the generic names. I think that's been asked a few times here. The reason we do that is because we always hope that someday it goes generic. So we try to train ourselves early on to use the generic name. So this is sacituzumab, which is harder to say. I have always said that I think that they choose really hard names to say, so we use the trade name. That's a joke. At any rate, there are ongoing studies right now investigating this exact issue, which is basically using sacituzumab, for instance, in combination with immunotherapy versus sacituzumab alone, to see whether or not there can be an enhancement of a response. So we don't know yet, but those studies are ongoing. The response rates, again, in triple negative breast cancer, is striking, but of course we have more limited options there. But again, there also has been seen an improvement in progression-free survival in estrogen receptor positive breast cancer. So they are sacituzumab. When I think of what I've got in my armamentarium these days for like an estrogen receptor positive cancer, it's astonishing. I've got things like the CDK4/6 inhibitors, palbociclib, abemaciclib, ribociclib. If there's a PI3 kinase mutation, I have I have alpelisib. If there's an ESR1 mutation, I have elacestrant. If there is a BRCA1 or 2 mutation, I have that. And then I can do things like, if it's HER2 low, I have trastuzumab deruxtecan, and then I have sacituzumab. I didn't even get to chemotherapy yet, guys. So that is remarkable. So we know that we are not doing well enough yet. We know that we are leaving people behind. But sometimes, what I've heard said is we try to get people to swing from one vine to the next vine, and our job is to keep coming up with vines. So that's what we're trying to do, is just keep coming up with another option.
Well, let's see. Do we have time for one more question, Casey? I'll try to squeeze it in. Is immunotherapy effective enough to be used alone without chemotherapy? How do you know if it can be used alone, or can it only be effective with chemotherapy?
Such another great question. There have been some really specific instances where immunotherapy alone is very effective, say melanoma, and in tumors that have what we call deficient mismatch repair. That is commonly seen in something called Lynch syndrome, which is mostly colon cancer, uterine cancer. A mismatch repair is not often altered in metastatic breast cancer, but when it is, then immunotherapy only could be considered. But in general, in breast cancer, immunotherapy only is associated with very low response rates, which is why we do it in combination. So in metastatic triple negative breast cancer, that's PD-L1 positive, we do it in combination with chemotherapy, but then we can often drop the chemotherapy and continue the immune therapy only, for instance. But we're still working on that. So we haven't given up on that approach, but right now, in general, it's given in association with other medications.
Can you talk about PARP inhibitors? What are they, and
Sure.
can they be effective in treating metastatic triple negative breast cancer?
Yeah, so I mean, PARP inhibitors are my baby. I've been involved in the PARP inhibitor development since it started, which is just really exciting. Right now, PARP inhibitors are effective in individuals that have either germline or somatic mutations in BRCA1, BRCA2, and PALB2. In individuals that have triple negative breast, and by the way, that's for estrogen receptor positive or triple negative breast cancer, both. In triple negative breast cancer that doesn't have those specific mutations, we're still trying to sort it out. There probably are tumors that are very responsive to PARP inhibitors, but we don't have a great test yet to figure out who those individuals are. But there is very active work going on in that space. So in general, we don't see, if it's just unselected triple negative breast cancer without those gene mutations, we don't see a lot of responses. But if we can get the biomarker right, you keep hearing about these biomarkers, if we can get the biomarker right, we can probably expand the group of individuals for whom PARP inhibitors would be helpful.
Which type of imaging is most effective at seeing metastatic ILC?
It's a good question. This is a very sneaky cancer, and the answer to that is, I'll give some hints as where it might go, but it's still an open question. ILC tends to spread in sheets in unusual locations, and so the stuff that we usually use, CT scans, are tricky. Bone scans can be helpful if it spreads to bone. So probably would still recommend that as a standard staging. For FDG PET CT scans, the ILC in its lowest grade form and its closest to the normal breast actually doesn't use much more sugar than the normal tissues. And so it actually evades even PET scans sometimes, which are often more sensitive. Right now, and this is not quite ready for prime time, the preliminary data suggests that one of the things that ILC preserves reliably, it's its estrogen receptor expression and its ability to bind estrogen. So I showed you one slide before on one of those new estrogen receptor tracers called fluoroestradiol, the trade name is Cerianna, that shows promise. And again, these studies are very early for being able to detect metastatic lobular cancer, with the exception of the liver where it's metabolized and it's a little tricky. So we're hoping to see these studies hit the next level of data and start around the country to try to develop more evidence on this. But that's one of the areas that is promising. There are a few other targets that are being looked at. There are differences in metabolism and other different approaches, but I think probably addressing its receptor proclivity may be the next way to identify spread. We've actually had some anecdotal success here at Penn doing some of that. So.
Very nice. And last question for you both to touch on: why is MBC research so important to you personally?
Yes, I'll go first. So I've been practicing medical oncology. I finished my fellowship in 2001. So I've been taking care of individuals with breast cancer for 22 years. And although, we've made significant strides forward, we still have way too many women die of metastatic breast cancer. And, because my area of expertise is in genetics, most of the women I see are very young. These are women in their 30s and 40s, who have children. And it's a tragedy for any woman to die of metastatic breast cancer, no matter what their age. But it's particularly heartrending to see significant disruptions in families. And so, every time we make some progress forward, it feels good, but until we completely obliterate this problem, it's not good enough. So it's very personal, because on a weekly basis, we have to have very hard conversations with people, and we would really rather put ourselves out of business, I promise.
And my answer is going to have some similarities there. In the imaging world, we do two things related to breast cancer detection. One is we do, through screening and diagnosis, identifying breast cancer early, and that has saved quite a few lives, and that's very important. And my colleagues who are breast imagers do that. As somebody working in the body side and the nuclear medicine side, we focus much more on identifying systemic disease. And again, in those patients that are diagnosed with breast cancer, it's not usually the primary breast cancer that kills the patient, it's the metastatic disease. So the focus on being able to identify the metastatic disease, earlier, and using imaging to help guide the right treatment has been something that I've been involved in since I've been in the early part of the career, and an area where the technology that I work with is particularly aptly suited for patients who have metastatic breast cancer, and probably less applicable to things like early detection. The flip side of that is that as an academic, I'm really indebted to the crowd of to those patients with metastatic breast cancer, because when we're developing these new technologies, we're asking patients to participate in trials and get a picture that we don't yet know how to interpret. And so we're taking data, and patients are giving their time and exposure to radiation in some cases, in the hope that these imaging studies will benefit patients in the future. And we're now seeing that happening. So as an academic, I'm particularly indebted among breast cancer patients to those with advanced and metastatic breast cancer patients who have been generous enough to participate in these trials, where, unlike therapy trials, there was very little benefit they were going to get out of these very early diagnostic studies.
Thank you. And just came in from Facebook, if there's time. I appreciate additional lines. What about a cure for ER positive? I know for triple negative, they have cures in research that look promising. Anything for ER positive?
Yeah, to be clear, no matter what type of metastatic breast cancer we're talking about, cures are elusive. Every once in a while, we have someone that we truly feel that we have cured, but we still feel, for the most part, no matter which bucket of metastatic breast cancer we're in, we do not cure, 99% of those. So what we're doing is trying to go vine to vine. So the cure happens, if you will, and the treatment of the early stage patient, and even then, relapses can occur very far out. If you notice, oncologists rarely use that word. We often use a word like no evidence of disease. We don't use the C word. We don't want to jinx anything. So it is a challenge for us. A part of what you're alluding to is that if you have an early stage triple negative breast cancer and you make it 5 years without a relapse, the risk of relapse after that is actually quite small, but the risk of relapse of an ER positive disease remains long. We do have active things. There's going to be another big presentation at ASCO this year trying to do better in that space. And so I think that we will continue to improve.
And if I could add a perspective from this, the one time I get to play oncologist is with things like thyroid cancer, which we treat with radioisotopes. Those are very slow moving diseases, and we can control them with some of the isotopes that we use, and patients may die with thyroid cancer, but they very rarely die of thyroid cancer. So one of the other goals is to say, even if you can't get to the point where you can document an eradication of disease, but you have enough drugs in your armamentarium to control that disease and contain quality of life, to me, in certain ways, that's a cure. If you live to a ripe old age and die with cancer, but of something other than cancer, then I think in certain ways that's part of the goal. And I just happen to have this peculiarity that in my strange little world of practice, we tend to work on tumors that persist, but can be controlled.
Sounds exciting. So, well, thank you so much for allowing me to moderate today. I'm going to hand it over now to Casey to close us out.
Yes, thank you to all three of you, Dr. Mancroft, Dr. Domchek, and Jamil. This was a really great discussion, chock full of way too much information for a single hour. So don't worry, guys. It's been recorded and it's going to be posted on our landing page shortly. If you registered, I'll also send it out via email so you can rewatch, share, and visit some of our other sessions for additional information as well. Please help us spread the word about the NBC Impact series to anyone that you think would find value in this content, friends, family, healthcare professionals, anyone that might be interested. And we also would like to acknowledge our sponsors of the 2023 Impact series one last time before we log off today, because their generous support is what allows us to bring this information to you. So a special thank you to AstraZeneca for being the technology sponsor for this year's series, and a special thank you to GE Healthcare for their support of today's event. And lastly, Walgreens and Merck as our signature sponsors. The series is made possible because of all of their generosity. Also, last note, please help us by completing a survey, which is now in the chat feature. Your feedback is really important. I'm the one who reads it, so it really does help us make sure we're getting the right information out to you guys and what topics are interesting. So please, please, please do not be shy. Lastly, the next event for the series will be June 16th and is focused on MBC and sexual health. That registration link is now live and on our landing page, so please feel free to register and share, and hopefully we will see you next month, June 16th. Thank you, everyone. Stay safe and stay connected.
Thank you.